One of the greatest problem of the greatest issue of treating elderly patients, and by elderly I'm really talking here about very elderly patients, the so-called elderly non-transplant eligible frail patients, more than 80 years old, and for many of them more than 80 years old, but a lot of handicaps and comorbidities on top. So for these patients, we have for a very long time identified that one of the drugs we use almost systematically was extremely toxic. And I'm talking here about dexamethasone. Dexamethasone is a drug that we hardly can imagine we would get rid of. And we keep adding to any of the regimens and to any drug, although all of us know that it's an extremely toxic drug. It's a drug that initially is very effective, but at some point, and it's something we can't appreciate, we cannot manage, we cannot study. At some point, there is a drop probably in activity, but there is an increasing a safety issue profile. So this kind of cross of curves, when the curves cross, you lose the activity compared to the increasing toxicity profile, or you lose the balance equilibrium between toxicity profile and activity. This is extremely difficult to appreciate in real life. And we only can appreciate it when the patients start having lots of side effects. But it's too late for patients that are very elderly and frail, because likely this patient would die from the side effects, and it's too late to appreciate that you should have stopped dexamethasone months ago before the side effects start to develop. So we and other, the Dutch and many other clinical trials groups and countries, we are looking into what could be the best regimen we could use in frail elderly patients upfront and in a relapse setting that would be extremely active without dexamethasone. And so we have looked into ixazomib, so the proteasome inhibitor oral boronate acid class, very convenient for the patients. Once a week, 3 times a month, so very, very easy to uptake. Plus daratumumab, no dexamethasone. So the patient had initially a little bit of corticoids to tolerate the daratumumab, but then after the corticoids was massively tapped down to make sure that the patient will be off corticoids. And in that study, we have recruited relapsed refractory myeloma, above 80, extremely frail. So we were very happy to see that there are safety issues, but of course we don't see safety issues in line with the corticoids and dexamethasone. We don't see this type of side effects anymore, and we were quite happy with the activity of that combination. So it was a phase 2, 1 arm. There is no way we could compare. So it's difficult to say that the activity is as good as if we had maintained dexamethasone. This is difficult because it was a 1-arm study. It was a proof of concept. But we believe there's truly something we could go forth here, which is a regimen, proteasome inhibitors plus anti-CD38 monoclonal antibody. The monoclonal antibody is sub-Q, the proteasome inhibitor is oral, and the whole regimen can be run without dexamethasone. And we believe this is very safe for these patients and probably very active as well. And dropping dexamethasone, we haven't had the feeling that we lost something in the regimen, in the activity of the regimen. So this is to develop further. Ideally, at some point, someone's going to have to run a phase 3 study to try to prove this in comparison to a regimen with dexamethasone indeed.